So we are live.
Good evening. It's a pleasure to have Dr. Rajesh Fogla with us today, and he'll speak on a very important and a common topic of practical importance, pterygium evaluation and management. This is not one of the focus areas of interest of Rajesh, but I requested him to speak on it because he's such a neat and a clean surgeon, and he gives the best of results in any case of corneal disorder. He is an excellent surgeon, and I think he would be a very good person to speak on pterygium because possibly his recurrence rate is 0, whereas everybody else's is like 30-40%. He's from Shankanetralaya. He did a fellowship there and he was a consultant on the cornea service. And he also initiated a cornea and refractive surgery service at Apollo Hospitals, Colombo. Currently, he is the director of cornea clinic at Apollo Hospital, Hyderabad for about 12 years now. And he still visits Sri Lanka. He has several awards. This is just to show a few, but I think the highlight of his career has been that he is an excellent teacher and a surgeon, and he runs his fellowship program and clinical skills transfer program, which is extremely popular internationally. He has been invited as a speaker for most of the international conferences. In fact, he's a featured speaker in most of the conferences, and he does extremely well at teaching fellows, and I'm sure he'll have a great talk today. So over to you, Rajesh, for your talk on pterygium.
It's a pleasure being part of the iFocus teaching program. And the topic that's been allotted is also very interesting. It's a very common problem that you see clinically. And although the management seems very simple, it's not as simple as what we think about it. So I'll be talking about pterygium, its clinical evaluation and management. And for all the participants who are joining this symposium, please feel free to ask any questions at any point of time. I will be happy to answer them for you. I have no financial interest in this presentation. When we talk about pterygium, it refers to a triangular wing-like growth, which is basically a fibrovascular growth consisting of conjunctival epithelium and hypertrophic subconjunctival tissue. It occurs in the horizontal palpebral fissure, usually located at the nasal limbus, more common than the temporal, and it often encroaches on the cornea, and it may arise from pre-existing pinguicula, which is histologically similar. Now, when we talk about a pterygium, the different parts of a pterygium, it consists of an apical cap, which is basically has a lot of fibroblasts, which release a lot of matrix metalloproteinase enzyme, and which results in destruction of the Bowman's layer. Ahead of it, you may also see iron deposition pigment line called the Stocker's line, as seen in this photograph. And this basically also tells us that the pterygium has been stationary, and this is because of pooling of tears that you get deposition of iron in the basal layer of the epithelium, giving rise to this clinical sign. The next is the head of the pterygium. That's the part of the pterygium that's encroaching onto the cornea from the limbus. And the rest, the second part is the larger part, which is the body, which is on the fleshy part on the conjunctiva from the limbus to the canthal region. In terms of the histopathology, the pterygium, the epithelium can be normal, acanthotic, hyperkeratotic, or dysplastic. It's been reported that almost 1.8% of cases, there can be dysplastic changes in the conjunctival epithelium. The underlying substantia propria shows elastotic degeneration, which is basically collagen that stains like elastin. And these are abnormal collagen fibrils, which are produced by the damaged fibroblasts. And the damage is because of the UV-mediated damage. In terms of prevalence, there is increased prevalence in the peri-equatorial region, 38 degrees north and south of equator. And males are more affected than females, especially working outdoors in the field with increased exposure to the UV rays. It's also seen more commonly with increasing age. Primarily, the pterygium seems to start between the age group 20 to 40 years. And there is one study where they looked at the the race, and they found that dark-skinned individuals, the risk of having a pterygium was almost 2.5 times more than the light-skinned Caucasians. Etiopathogenesis of pterygium is multifactorial. Some of the common inciting factors are the UV exposure, and Minas Cornea from Australia published an article where he proposed the hypothesis that the nasal pterygium occurs mainly because the UV light gets reflected from the bridge of the nose and gets concentrated at the nasal limbus. That's why it's more frequent at that site. Microtrauma also plays a role, whether it's the sand, dust, or the exposure to wind and the drying effect in the interpalpebral region that initiates the pterygium. There have been some studies where they have looked at hereditary occurrence of pterygium in families. So they have also studied the genetic predisposition. There have been expression of p53 oncogene in the epithelial cells. And this gene basically regulates the maturation and multiplication of cells. And this can also lead to dysplastic changes. So that also may have a role in the etiopathogenesis of pterygium. The other thing that they looked at the dysplasia was that if you use antimetabolites when you excise pterygium, that seems to stop the recurrence of pterygium, or it retards further proliferation. So that also kind of plays a role in the dysplastic, underlying dysplastic changes. The second thing that we also look at is a focal limbal stem cell deficiency, because the pterygium, the conjunctiva invading the cornea, also has features of conjunctivalization, where you have conjunctival epithelium coming onto the cornea and the loss of the limbal barrier. And when you do a conjunctival limbal autograft, this seems to prevent the recurrence because the limbal stem cell population is repopulated. So that again may have a role that the focal limbal stem cell deficiency could be responsible for the progression of pterygium. And recently, people have also looked at the role of human papillomavirus in the causation of pterygium. In the clinical presentations, you may have a patient who's asymptomatic and has a pterygium. And this happens commonly when you see patients who come with decreased vision and has a cataract in the eye, and you plan for a cataract surgery, and you see that the patient also has a pterygium for which the patient is not really bothered about it. Or you can have patients who present with symptoms of irritation, foreign body sensation, dryness. And this can happen because the pterygium, by its physical presence, results in a shortened tear breakup time, and it can cause disturbance in the tear film, and especially while blinking, people can experience foreign body sensation. Visual disturbance can also occur from the induced astigmatism. As you see from the topography that we show here, the nasal pterygium induces a flattening of the horizontal meridian. So you have with the rule astigmatism, which can also result in decreased quality of vision. And this is important if a cataract surgery is planned, because without excising the pterygium, if you take the astigmatism into account and do a toric IOL, later on when the pterygium is removed, you may have undesirable outcome as the astigmatism is going to go away. Pterygium can also give visual disturbance if it encroaches onto the central cornea, impinging on the visual axis. And recurrent pterygia can sometimes result in restrictive ocular movement, resulting diplopia in certain directions of gaze. Patients often come in with impaired cosmetic appearance. They feel that there is a reddish appearance of they are traumatic from the point that the eye doesn't, and they want a better. Clinically, when is my connection okay? Because
yes, sir, no, sir, your connection is a little unstable. Yes, sir.
Yeah, it must be okay now. Is it okay?
Yes, sir.
Yeah. The other reason clinically, you may also see with pterygium with overlying dyskeratosis, keratinization, or sometimes there may be abnormal pigmentation. That can also be seen clinically. In terms of grading of pterygium, one way to grade a pterygium is the degree of encroachment on the cornea. So when you have grade 1 where the pterygium is not yet invaded the cornea. It's like an extension of the pinguicula, whereas grade 4 is a pterygium that's almost encroaching onto the visual axis. As you see in this clinical photograph, the picture on the extreme right, that's a very early pterygium going onto the mid cornea, and the last one is where it's almost coming onto the visual axis. So thereby you can grade the pterygium in terms of severity.
So your connection is unstable
all of them
again,
can
sir.
undergo surgery. I can reboot my router if it is, if you give me a minute in case if it is causing problem, because that is something that is not in my hands. I just,
So you
I'll
can
take
go
a
on,
break
it's
for 2
clear
minutes
now.
and I'll be back. I can go off, it's clear. Because it depends,
now.
my internet connection is like that only. It's okay.
I can hear you.
The other way of grading the pterygium, the other way of grading the pterygium is the TANS grading system for pterygium, which he published in Archives of Ophthalmology in 1997. Now here, the pterygium is graded not in terms of the degree of involvement of the cornea, but in terms of how well you can visualize the underlying episcleral vessels. So in grade 1, you can see the underlying episcleral vessels quite clearly. In grade 2, there is partial obscuration of the episcleral vessels. And the grade 3, where the pterygium is really fleshy, you are unable to see the underlying episcleral vessels. Now, if a surgery is performed in these kind of 3 patients, the chances of recurrence may be higher in a very fleshy pterygium, like the grade 3, as opposed to the grade 1 pterygium. So this pterygium gives us some clinical idea of the surgical approach that we need to take and what kind of post-op regime that we need to follow with topical medications. And also we can prognosticate the outcome of the pterygium looking at the grade of the pterygium as well. We can also classify pterygium as primary pterygium and recurrent pterygium. Primary pterygium has all the features that we discussed earlier. A recurrent pterygium may not show you all the typical appearance. There may be a very broad involvement of the cornea. As you see in this case, there is, the conjunctival tissue is shortened, there is scar. The medial canthus and the punctal opening, they're all pulled towards the cornea, showing formation of symblepharon. You can classify pterygium as like a typical pterygium and a pseudopterygium. This is again something that is important for postgraduates. A pseudopterygium is basically addition of the conjunctiva to the cornea. It can occur at any location. It can commonly occur after trauma, after chemical injury, or any inflammatory peripheral ulcerative keratitis, where you get addition of the conjunctiva to the cornea. Sometimes you can pass a probe through the conjunctiva, through the folds of the conjunctiva under the addition between the cornea and the conjunctiva. Often these are non-progressive, unlike a typical pterygium. And we also can define pterygium as a single nasal pterygium or a double-headed pterygium where you have a nasal and temporal pterygium as well. In terms of differential diagnosis, we can, like one of the differential diagnoses is pseudopterygium, where the pterygium is not in the typical location. It can occur anywhere. It can be have a much more broader involvement. The other lesions which may sometimes be confused are limbal dermoid, which is again located in the limbus, but it may have other features like presence of sebaceous glands, the hair follicles, and its typical disc-like appearance. You can have flictendular conjunctivitis, where as the conjunctivitis progresses across the cornea, it can drag some of the conjunctival vessels and some conjunctival tissue across the cornea. Ocular surface squamous neoplasia can also occur at the limbus. And this is something very important that needs to be differentiated from a pterygium. Ocular surface squamous neoplasia will stain with rose bengal. It will have prominent feeder vessels. It will have those keratin plaques. And usually, these are some of the points with which you can differentiate from a pterygium. A conjunctival lymphoma can also sometimes be confused. And if you have scleritis or sclerokeratitis, then also you can have corneal opacification, and sometimes the conjunctiva can become more congested in that quadrant, and you can confuse that with an early pterygium as well. So in terms of management of pterygium, It's not that complex. A pterygium, if you have a patient presenting with a pterygium and the patient is asymptomatic and does not have any impact on the vision or cosmetic appearance, then you can basically document the pterygium, take photographs so that you can monitor and you can see for progression, and you prescribe some lubricants which can make him feel better. So that's what you do. But if the patient is symptomatic, you look at the grade of the pterygium. So if it's the early pterygium grade 1, which is atrophic, again, if the patient does not have any impact on the vision, you don't need to do anything. But if the patient is unhappy with the cosmetic appearance, or if there is some impact on the vision because of increased astigmatism, or if a cataract surgery is planned at a later date, then you can consider surgical excision. If it's a fleshy pterygium, then sometimes it can be pre-treated with topical NSAIDs or steroids. And these, if treated for 4 to 6 weeks, can reduce the congestion in the pterygium, and somehow it can also reduce the recurrence rate when the pterygium is excised. However, if you see any pterygium which has keratinization or pigmentary changes, especially in an elderly individual, I think you should plan a surgical excision and submit the pterygium to histopathology so that any dysplastic changes can be ruled out. Anything at this point of time, if there is anything to be discussed before I move on to the surgical management?
So we'll move on with the surgical management.
Okay, great. So in terms of surgical management, it's important to, although we currently look at the conjunctival autograft or the conjunctival limbal autograft as a gold standard, but in terms of the surgical excision, pterygium surgery, it started off with the bare sclera excision or excision with primary closure of the conjunctiva, or bare sclera excision with antimitotic adjunctive therapy, or the excision with ocular surface reconstruction using conjunctival or conjunctival limbal autografts with or without amniotic membrane transplantation. Now, the bare sclera excision were described by Ombrain in 1948. It's a simple excision of the head and body of pterygium. This is a video that I borrowed from YouTube. And here you can see that the surgeon is holding the head of the pterygium and peeling it off the cornea. And then once it is peeled off from the underlying sclera as well, he is excising the exuberant fibrovascular tissue. So that's the body of the pterygium, the excessive fibrovascular tissue. And then you cauterize the bed to control the bleeding. And then you take the conjunctiva, and the head and part of the body is excised. And then the conjunctiva is just fixated to the episclera using Vicryl sutures. Now, this technique, although it's quite popular, and I've seen a lot of surgeons perform this in 5 to 6 minutes, it is associated with a very high recurrence rate, and it's been reported anywhere between 24 to 89%. And also, depending on if you have cauterized the sclera quite a bit, sometimes there can be delayed healing of the delayed epithelial healing, and you have increased chances of complications. You can get scleral necrosis, scleral infections. Sometimes you get symblepharon formation, and with the associated diplopia as well. The other technique people like to do is excision followed by primary closure of the conjunctiva. Now, the primary closure can be a simple closure, or it can be like making relaxing incisions in the conjunctiva and then preparing a sliding flap to bring down the conjunctiva and close the defect. Again, this technique, although surgically it's nice to perform, it's been associated with high recurrence rate of almost 37 to 39%. Use of antimitotic adjunctive therapies have reduced the recurrence rate compared to the bare sclera and the primary closure. Beta radiation using strontium-90 was described earlier, and it had the reported recurrence rates were only about 10%. However, with this, you had these delayed scleral melt, infections, formation of cataract, dry eye, you could get ocular surface disease due to associated limbal stem cell dysfunction. So currently, this is not very popular. This is again more from a historical perspective that this was an option for surgical excision of pterygium. What was popular and is still being performed is the use of mitomycin C. Mitomycin C is an alkylating agent that inhibits cellular division by inhibiting cellular DNA and RNA. Eric Donenfeld had described a series of cases where preoperatively they injected mitomycin C 0.01 ml of 0.15 milligram per ml. That's about 0.01%, 0.01 to 0.02% of mitomycin into the pterygium 1 month prior to the surgical excision. And they reported a recurrence rate of about 6%. Now, the way this works is it basically mitomycin C, it inactivates the fibroblasts, so the proliferative capacity of the underlying substantia propria is reduced. So when you excise the pterygium and you do a primary closure, you have a lower recurrence rate. Intraoperative application of mitomycin C is something which was more popularly performed. Again, 0.02% for time duration ranging from 30 seconds to 5 minutes. And reported recurrence rates have been variable from 3 to 43%. However, the application of mitomycin C also has been associated with delayed in case of
Hello, sir.
use post.
So we lost
Yeah,
your
I think
voice
my
again.
internet connection. Yeah, it'll get better.
Okay.
Yeah. Am I back now?
Yes, you're
Yeah.
back, sir.
So I was talking about the intra-op application. That was clear?
Yes, sir.
I can repeat this slide if this was. We have pre-op injection of mitomycin C. You have intra-op application of mitomycin C. And the third option is post-operative use of mitomycin C as eye drops in 0.02% concentration, used 4 times a day for 1 to 2 weeks post-operatively. Again, various studies have reported recurrence rate ranging from 0 to 38%. The associated complications have been scleral melting, scleral or corneal perforations, secondary glaucoma, or the formation of cataract. Now, these are some of the complications that you can see, and usually happens at the site of pterygium excision and the underlying, if you have especially if you have done a lot of aggressive surgery with a lot of cautery, and if you apply mitomycin C, you can have this kind of delayed healing, and then you can have the scleral thinning and scleral melt, and sometimes that can get secondarily infected, leading to infectious scleritis as well. And clinically, if this presents, then it's a medical emergency. You have to manage this using conjunctival or scleral patch grafts. The excision of pterygium with ocular surface reconstruction using conjunctival or conjunctival limbal autograft, with or without amniotic membrane graft, is currently the procedure of choice, often referred to as the gold standard. It's a safe procedure with low recurrence rate and excellent cosmetic results. There are various randomized control clinical trials comparing conjunctival autograft with mitomycin application, and they have shown that the recurrence rate with CAG is about 1.9 to 4% versus 5.8 to 20% with mitomycin C application. There are RCTs comparing conjunctival autograft to amniotic membrane transplants along with pterygium excision, and they have found that the recurrence rates are lower with the conjunctival autograft compared to using primary amniotic membrane grafts. Now let's look at a surgical excision of a pterygium. So this is a patient who has a nasal pterygium. The surgery is usually performed under peribulbar or regional anesthesia. Although if you have a very cooperative patient, you can even do it under a subtenons or a subconjunctival anesthesia as well. But the problem with using subconjunctival injections is that it balloons your conjunctiva, and sometimes you lose your normal anatomical landmarks, which you would like to have when you are dealing with surgical excision of the pterygium. So I like to do my procedures under peribulbar anesthesia. So I mark the pterygium, the junction between the head and the body of the pterygium. Use a marking pen and mark that. And then you can, if you want, you can inject a little bit of xylocaine. So this patient, we are doing it under a subconjunctival xylocaine injection because it's a small pterygium. But I have made the mark where I'm going to make the incision before I inject, because if I inject and then it balloons up the conjunctiva, sometimes it's difficult to define where you're going to exactly make your incision. So we use a Westcott scissor and we cut only the conjunctiva. So we don't try to disturb the underlying the fibrovascular tissue. So we are just excising the conjunctiva. Placing a drop of bribonidine before you start the surgery gives you some amount of vasoconstriction. So intraoperative bleeding can be controlled better. And also using these kind of small pieces of Wexel or the Mercel sponge also helps absorb the blood and does not pool the blood in your surgical field. I'm using a number 15 Bart Parker blade, and I'm using the blunt dissection with this blade to excise the head of the pterygium from the cornea. So if you use a blunt dissection, you can usually get the plane and you can remove the head of the pterygium. And that's the tissues of the limbus which are there, which I'm just using a Vanus to excise that. And then I'm using the number 15 blade to smoothen the limbus, because there are usually some fibrous. So you want to have it nice and smooth so that when you put in your conjunctival autograft, it sits very well. So you can see that after you have done that blunt dissection, this is nice and smooth. You watch out and look for the bleeders. And if there is any bleeding, you can either control it just by putting a Mercel sponge, or you can use light cautery. So now we pay attention to the fibrovascular portion. So you try to excise, you pull on you basically separate the fibrovascular tissue from the conjunctiva before, and then you can excise the fibrovascular, the exuberant tenons. This is a very small pterygium, so we are not doing an extensive dissection. Maybe when we come to the next video, we will show you that the amount of, so if it's a very fleshy pterygium, you have to remove more amount of fibrovascular tissue to get a nice thinning of the surrounding conjunctiva. It's always important that you measure your size of the conjunctival autograft and not make a size just based on visual assumption. So mark out the points. You can take it from the superior or superotemporal, especially if you feel that this patient is going to require glaucoma surgery in the future. Then you can even try and take your graft from the inferior limbus as well. For a primary pterygium, you don't really need to include the limbus in your conjunctival autograft. But if you do have a recurrent pterygium or a very fleshy pterygium where the chances of recurrence is higher, then you can consider carrying forward the dissection of the graft a little bit into the cornea, so you can get the pigmented palisades of Vogt in your conjunctival autograft, and you can have a conjunctival limbal autograft. So here we are just discussing dissecting the conjunctival autograft, and use very gentle dissection. Don't try avoiding a buttonhole. And you can see that just so we try to avoid getting tenons. And if you don't disturb the tenons here, you can even leave this layer bare at the end of the surgery to reepithelize, and it will reepithelize very well. But if you have disturbed the tenons here, then if you don't cover it, you can have the risk of formation of post-op tenons granuloma superiorly at the donor site as well. So try not to disturb the tenons from the site where you're harvesting the graft too much. So also we have marked, so we know the orientation. So we have to maintain the same orientation. That means the limbus to limbus, what was the orientation, we try to maintain the same orientation. Although if you were to accidentally put it the reverse way, not the upside down, but if you were to put it the opposite direction, you will still have a good outcome, except that cosmetically, sometimes the blood vessel may not follow the same pattern as what you were seeing here. So if you want excellent cosmesis, then it's important that the orientation should be maintained. So we lay the graft down on the site where we have excised the pterygium. I like to start off by putting 2 sutures at the limbus. And it's important to oversize the graft by 1 millimeter from the size of the defect that you have. and not to undersize the graft, because then you stretch it and then you can have peripheral gaps through which the fibrovascular tissue can, encroach in the postoperative period and resulting in a recurrence. I use 10-0 nylon to place my sutures, but you can use white krill as well. White krill can become loose, frayed, or it can become loose early in the postoperative period, whereas nylon stays for a longer period of time. So that's the reason why I prefer nylon. And these sutures, I can remove it in the first 1 or 2 weeks post-op. If you see the patient on slit lamp, you can use a 27 gauge needle to just break the sutures and pull them out. So usually we put 4 stay sutures at the 4 corners, and then we place these sutures. When taking these sutures, don't take the suture only through the conjunctival graft and the adjoint, but small epidural bite. Which looking the
So the network.
have been removed.
So your network is unstable, sir.
So that's the post-operative appearance. You can see that's the pterygium and that's the post-op appearance. So one of the other objectives of pterygium is to try and achieve a very good cosmesis. So for me, if I do a pterygium surgery, I don't finish it in 5 or 10 minutes, but it takes me a good 30 to 40 minutes to complete the surgery, because we want to make the conjunctiva look so good that post-operatively the patient should not be able to even know that there was a pterygium existing earlier. Currently, it's more popular to use fibrin adhesives when doing pterygium surgery. The ones that are currently available are the TCL from Baxter, which we use. The other one is Seal from Reliance. However, I use both, but I prefer to use the TCL because it's much more, it gives a better adhesion. These are biological and biodegradable adhesives. It has 2 components, fibrinogen and thrombin. When mixed, the fibrinogen is activated by thrombin to form an adhesive fibrin network. Advantage over sutures that reduces the operative time. Compare study between fibrin and the suture autograft that the use of fibrin glue reduces surgical average of about 18 minutes. They have also reported lower recurrence rate, but in my hand, it's pretty much the same. It gives great operative comfort because you don't have the sutures in the eye. Disadvantage of fibrin glue is it's expensive, and there is always, because it's a blood-derived product, there is always a potential risk of transmitted infection. However, there is nothing that's been reported in literature so far. The other popular technique is the use of autologous blood in situ coagulum. Basically, this is at the bed of the pterygium where you have excised the pterygium. When you put in your conjunctival autograft, you try and nick one of the blood vessels to induce some bleeding, and then you put in the conjunctival autograft and you allow some blood to accumulate below the conjunctival graft, and you apply pressure for some time. So you get the blood coagulum that forms, and that kind of provides the adhesion for the conjunctival graft to stick. Disadvantage of that is you don't have a very flush underlying surface, so you have some blood that's between the graft and the underlying sclera, and the cosmetic appearance in the early post-operative appearance is not too great because of the underlying hemorrhage. And because the adhesion is not as strong as the fibrin adhesive, you have to be a little careful in terms of the patient not rubbing the eye, or you have to patch the eye in the initial 24 hours using a tight patch, so the graft does not dislodge or does not dehisce from any of the margins. But there have been comparative studies looking at the outcomes between fibrin glue and autologous blood, and they have found that the outcomes, both in terms of recurrence rates and the comfort level, they're quite comparable. In my personal experience, I have not used autologous blood barring a few cases, but I think in my hand, the fibrin glue works much better. So let's look at this. This is again a pterygium. This is slightly broader. So we use the same marking at the junction between the head and the body. So you can see here we have so you can control the bleeding quite well using this Merocell sponge. So this is the important part that is very important to prevent recurrences, is that you do a dissection between the conjunctiva and the underlying fibrovascular tissue. So you have, if you have an assistant, your assistant can hold up the conjunctiva using a non-tooth forceps, and then you can use your blunt tip scissors to cut the fibrovascular tissue or the tenons from the conjunctiva. So you do this all around until you get a nice wide separation. And this also helps thin down the surrounding conjunctiva, so that when you put in your conjunctival autograft, the edge of the autograft and the edge of the conjunctiva are quite flush. Without doing this, if you do that, you always find that there is a ledge that's left. Your autograft seems thinner and the surrounding conjunctiva looks thicker. So cosmetically, it's not too great. And also this fibrovascular tissue that you have left behind also has a greater propensity for recurrence. So this, I feel, is a very important step, that you just retract the conjunctiva and you dissect the fibrovascular tissue from the conjunctiva as far as possible. And once you have done that, you can then excise that exuberant tenons tissue. So you can see that we give it a pull and we remove this. I'll come back to the recurrent pterygium, where this is important that you don't do a blind excision of this exuberant fibrovascular tissue, because sometimes in that scenario, you can have the tissue enmeshing the horizontal recti, the medial rectus or the lateral rectus. So you need to identify that before you excise the exuberant fibrovascular tissue. So we do the dissection, come close to the limbus, and at this point of time, you can initiate your dissection from the corneal side using a blunt 15 number blade. So this, I usually start by debriding the epithelium ahead of the apical cap. So once you have debrided the epithelium, and then you can gently back dissect using the blade as a blunt dissector. So you don't use the sharp edge of the blade, you hold the blade vertically and gently scrape the cornea. And you will find that you get into a plane, and then that ensures that you don't have any remnant of the pterygium left behind. So there will be a stronger adhesion at the limbus. So you can dissect very easily from the cornea. You can dissect from the sclera, the fibrovascular tissue. But when you come to the limbus, sometimes you may need to use a Vannas or something to excise the tissue. And then you can use a number 15 blade to do a blunt scraping to make it smooth. If you have a diamond burr, you can use that to polish this. If there are any so the only cauterization that I've done in the entire surgery is somewhere close to the limbus, or if you see some prominent blood vessels where you can expect some bleeding to occur, especially when you're suturing, but if you're using fibrin glue, you may not even need to do that. Or for sometimes for cosmesis, better cosmesis, if there are very prominent blood vessels and you don't want them to be seen postoperatively, you can then gently cauterize them. But it's important to remove this irregularity from the limbus. And this is important because it allows rapid epithelialization, and also the limbal stem cells can proliferate better. So once you have done this, so here what we are doing is, when you do the dissection, the defect looks much larger. So before you go and measure that and put in your graph, you rearrange your conjunctiva, and here I'm using the component 1 and component 2 of the fibrin glue. I'm applying the first component. Yeah, and then you apply the second component. So you apply the fibrinogen followed by the thrombin. what I'm doing is I'm basically fixing this conjunctiva first. So I remove the excess of the fibrin glue that's under the conjunctiva, and I get a nice flat, I iron out the conjunctiva. So because there will be some folds in the conjunctiva, so it's important that you do that. And then you get the size of the bed that you have. You make measurements of that, both the vertical and the horizontal, and then you can come back and mark your site from where you're going to harvest your donor graft. So you put in your marks, mark out with a marking pen, and then use scissors to make the 2 vertical incisions, and then I use the scissors to dissect the tenons from the conjunctiva. It's all done gently and under proper visualization so that you don't get any buttonholing. So you can see that I'm not taking the limbus. This is just a conjunctival autograft. You lay the tissue flat on the cornea and you can leave it there. So you don't really need to pick it up. So that way, maintaining the orientation is much easier. So here I'm planning to close this defect. So simply pulling the conjunctiva and closing it is not going to work. So we have to separate the conjunctiva from the tenon so that then you can pull the tenons, the conjunctiva, and make the closure. Otherwise, without doing this step, if you try to close this just by pulling the conjunctiva down, you also pull a lot of tenons down, and then this area sometimes has a little bit of a boggy appearance. So if you do a little bit of separation, then it's easy. Then again, I go and put a little bit of my fibrin glue. The component 1 and the component 2. And then you can use 2 forceps to hold the conjunctiva and close the defect. Comparatively, if you close it, it gives a little bit more comfort to the patient post-operatively as opposed to leaving it bare. But then you have to monitor it till it's completely epithelialized. So this is, so both ways it works very well. So here I'm taking the conjunctival autograft and I'm laying it on my bed. And you can see that although it may look a little small, but because if you have done your measurements, it's going to fit really well. And that's really important from the cosmetic point of view, because if you have a much larger graft, it bunches up in the periphery and doesn't really become nice and flush. If it is shorter, then you find that it's retracting from the edges and you're not able to get a good closure. So now you can see that even before I've applied the fibrin glue, I'm checking it out and I can see that it's fitting really well. Now, the difference that I do when I do my fibrin glue in conjunctival autograft is that I like to
So your network is unstable again, sir. The video has paused too.
So the advantage of putting these 2 stay sutures at both the edges of the graft is that, okay. So I have placed 2 sutures here. So then it's like a LASIK flap. I can lift it up and I don't have to worry about the flap moving around too much. So I place the thrombin here and the fibrinogen there. So I place them as separate components and I don't put excessive amount of glue. Then you can put in your graft and you can stretch it very well. Because my 2 edges are fixated, I have no problem in stretching my graft, which if I had not fixated this and I try to stretch, I find that I have to use another instrument to try and fixate one edge while I'm doing stretching the other edge. So this way what happens is I'm able to get a very nice flat graft without excessive amount of fibrin glue below it. So we iron out all the excessive fibrin glue, and at the end of it, we put a bandage contact lens on the eye. So that's again the post-operative appearance. You can see that's the pterygium. You have the early post-operative where you can see the two stay sutures at the limbus. These usually I remove it by the 5th or 6th day on slit lamp, and that you can see a couple of weeks later, the conjunctiva, and you can even see the underlying episcleral vessels are seen very clearly, and the graft can barely be made out. This is another similar case where you can see the two stay sutures at the limbus. The conjunctival autograft is really thin, but the best part is if you look at the surrounding conjunctiva, you don't see a large, gap or a difference in height between the graft and the surrounding conjunctiva. There's another surgical technique called the perfect technique, which is pterygium extended removal followed by extended conjunctival transplantation, described by Laurie Hurst from Australia. And he has several series with ranging from 250 to 1,000 eyes and follow-up of over 1 year. And he has a 0% recurrence rate for primary pterygium and only 1% recurrence rate for recurrent pterygium. However, in his case, he removes the conjunctiva all the way up to the canthus. So it's a fairly large removal of the pterygium and the overlying conjunctiva. And to cover that, you need a fairly large conjunctival autograft as well. And this is one of his results where 250 eyes, 0 recurrence rate follow-up, minimum follow-up of 1 year, and the pre-op and post-op appearance. And he claims that because you excise the entire conjunctiva right up to the canthus, so you get a very nice cosmetic appearance as well. This is again just a surgical technique just for clinical records. This is again double-headed pterygium. So what we did was, and you can see it's quite fleshy as well. So here I'll quickly jump to the rest of the surgical technique is the same. We excise all that exuberant tenons, scrape and remove the pterygium, and then we kind of reduce the size of the defect, because when you mobilize the conjunctiva, the defect becomes much larger. So you iron out the conjunctiva and see what is the, so if you're not using fibrin glue, then you can put some episcleral bites and then close the conjunctiva, keeping the bulbar conjunctiva flat. So you have an exact idea of what the size of the conjunctival autograft would be. So we do the surgery on one side and we come back on the other side, excise the pterygium. And then when we are preparing the graft for, so that's the final size of the bed that what we will require, we do the measurements. And then we come back. And here what I'm doing is I'm going to take a much larger size of the graft, because I'm going to take the graft. You can see I'm marking it. And we are going to split this graft into two. So we are going to make, so we put that mark and then we have the size of the two grafts that we are going to use, one nasal and one temporal. It's important to create this mark beforehand rather than excise the graft and then try to split it into two when it can be unequal and you may have difficulty because the graft kind of crumples up once it is prepared and excised from its natural position. So prepare two grafts, we do the dissection, excise the first, and then we do the second. And then we can place the grafts on both nasal and horizontal temporal side. And we can jump to the end of surgery just to show you what it looks like. So you can see that that's the end of surgery with the two conjunctival autografts in place. Now in this case, we did both the pterygium surgeries at the same time. The other option that could have been that we could have done the surgery one at a time. We could have done the larger pterygium first, taken the conjunctival autograft from the superior bulbar conjunctiva, not pull the conjunctiva down to close it, let it reepithelize, and you can come back a few months later, operate the second pterygium, and again take the graft from the same side. The second option is to take the graft from the inferior limbus as well, or if the fellow eye has uninvolved ocular surface and no pterygium, You can even harvest the conjunctival autograft from the fellow eye. Now, this is a recurrent pterygium, where you can see this is a large pterygium that's coming onto the cornea, and there was some restriction of movement as well. Now, when you're operating in these kind of eyes, it's something that you can see there's a recurrence and there is shortening, and there is, you can see that's the edge. So the normal landmarks, what you see in a primary pterygium, are often not seen here. And if the primary surgery has been done by a different surgeon, there are a lot of things that as an operating surgeon, you may not have idea. So we do the surgery, again, doing the same thing. We excise at the junction of the head and the body, and then we start the dissection. Be prepared for more bleeding, and the adhesions, the anatomical planes are usually lost in a recurrent pterygium, and it's going to be a little bit more challenging and more difficult. So you need to dissect more than what you would do in a regular pterygium. So here we do the dissection, and you have to tag the muscle, like what I mentioned earlier, that you tag the, here it's the lateral rectus, so we are tagging the lateral rectus. And after you have tagged the lateral rectus, then you can continue with the further dissection, and then you can excise the exuberant fibrovascular tissue as well. This is one scenario where you may want to use a local application of mitomycin C to prevent recurrence as well. And sometimes we also like to use amniotic membrane. So here you can see we harvested the conjunctival autograft from the normal looking site, prepared our graft, and that's the amniotic membrane. So because the bare area is much larger after the dissection, we were not able to harvest such a large conjunctival graft. So what we do is, in such kind of recurrent pterygium, we use amniotic membrane to cover the entire bare area. So here we are using fibrin glue to place the amniotic membrane, secure it in place, excise the excessive edges, and it's also covering part of the cornea where we have done our dissection. And once you have done that, you can then place your conjunctival autograft over the amniotic membrane. And here also, I like to suture at the limbus just to secure the conjunctival graft in place. And then you put a large diameter bandage contact lens. In terms of postoperative management, you use topical antibiotics for 1 to 2 weeks till the epithelial healing is complete. Topical steroids are used for 2 to 3 months in tapering dosage. It's important that you watch out for steroid responders, because often you can have patients after using steroids for a week or two, they can have significant rise in IOP. And the topical lubricants have to be used for a period of 3 to 6 months. So the usual follow-up schedule is we see them on day 1, then we see them on day 5, because day 5, by the time that corneal epithelium should have completely healed. And then we see them at day 14. By then, the graft also should have settled down. And if there are any sutures in place, we tend to remove it at day 14. And we also check the pressure and watch out for any steroid responders. And then we see them at 1 month and then three months follow-up. Complications, yes, you can have complications with conjunctival autograft. You can have graft edema. You can have hemorrhage under the graft. If your graft is very edematous, you can have the adjacent delin formation in the cornea, which is very important, because if you don't watch out, that delin can cause significant amount of corneal thinning, and you can end up with problems which may be difficult to manage. So if you do see a delin, increase the lubrication, or you can give some ointment application, which will result in better wetting of the area and the resolution of the delin. If your graft is very edematous because of the serous fluid under the conjunctival autograft, you can use a needle to make a few punctures in the conjunctival graft, and then use a Merosol sponge or a cotton bud to kind of express some of the fluid. You can have graft displacement or retraction, especially if you're using fibrin glue or if you're using autologous blood. And in certain rare situations, you can have loss of the graft. And this is especially if there is excessive amount of fibrin glue under the graft or excessive amount of blood under the graft. You can get formation of Tenon's granuloma at the site of the pterygium excision or at the site of from where you have harvested the donor. These usually respond well to topical steroid, but if it is fairly large, you can even consider a surgical excision, excising them at the pedicle. And the late complications, what you see is the recurrence of the pterygium. This is a very nice paper by Harminder Dua, where they have studied the healing of autologous conjunctival grafts in pterygium surgery. This is a free access paper in Acta Ophthalmologica 2018. And there are some images that I borrowed from this article showing the retraction of the edge of the conjunctival autograft. There is another photograph showing you the serous fluid under the graft with retraction of the edge. So this serous fluid comes from the underlying blood vessels. You can have bleeding from the underlying blood vessels under the graft leading to this kind of a hemorrhage. This will be the typical appearance of the graft if you are using autologous blood as well. And the last image is showing you the Tenon's granuloma. Again, increasing the steroids or continuing them for a longer duration of time can result in resolution of the Tenon's granuloma. What about recurrence? Well, the best way to manage recurrence is to avoid recurrence. So do a meticulous primary surgery using a conjunctival autograft technique. In the follow-up period, if you see early recurrence, it can be managed by stepping up the topical steroids. Some people have also reported management using subconjunctival injections of 5-fluorouracil. It works the same way as what you do for a failing conjunctival bleb. Or people have also tried using anti-VEGF agents. But again, anti-VEGF agents have a short-lived effect, so it requires multiple injections. And if everything fails, then you have to consider a repeat surgery using antimetabolites such as mitomycin C application and use of amniotic membrane graft to cover the large defect. And in this scenario, you don't have to use just a conjunctival autograft, but you have to use a conjunctival limbal autograft so that the limbal barrier can be further restored. So basically, in conclusion, pterygium is a common disease in tropics, often requires surgical excision. Conjunctival autografting is currently the gold standard for surgical treatment. Meticulous surgery and the use of fibrin glue can reduce recurrence rate and give excellent cosmetic outcomes. Intraoperative mitomycin C application has a definite role in recurrent pterygium surgery. Amniotic membrane transplantation, not a primary role, but it has an additional role in surface reconstruction. Extensive for to so 8:57. So we have taken about exactly 50 minutes.
Yes, sir. So thank you so much for the amazing lecture and the wonderful surgeries. And I think that when we used to do the pterygium surgery, I believe that the suturing part would have been very helpful. I think I would really like to try that sometime. So there are a few questions that we would like to take.
Please go ahead. Yeah, definitely go ahead.
What is the role of immunohistochemistry markers in pterygia?
When you talk about immunohistochemistry markers, which markers are you referring to?
So P53 and Ki67.
Yeah, from the clinical perspective, I think it's more from the etiopathogenesis of pterygium. If you really want to look at the dysplastic changes in the pterygium, so if you're doing a research study, then you can definitely, all the excised specimens, you can subject them to immunohistochemistry to look for the P53 gene. But in terms of clinical management, I don't think that really makes any kind of difference. So I don't think you really need to subject every pterygium to a immunohistochemistry.
Right, sir. So in patients that have cataract as well as pterygium, yes. What do you recommend? Like at which point when should the pterygium excision be done? Before the cataract surgery, with or after?
Ideally speaking, you should do the pterygium surgery before, and then you can come back and do the cataract surgery later, so that whatever astigmatic changes are induced by the pterygium, they will go away, and then the patient can have a better refractive outcome from the cataract surgery. But if you have a very small atrophic pterygium and there is no significant astigmatic effect, and the patient is not opting for a toric lens, then I think you can sometimes even do it simultaneously, or even leave it. If it is just an atrophic pterygium not affecting the vision, you can just go ahead with cataract surgery alone.
So is there an undercorrection that should be left in that case?
Undercorrection of spherical, cylindrical power, which one are you referring to?
Or like a combination, sir? Because
No,
toric might be
like,
required.
no, if your pterygium is not inducing any cylindrical changes on the keratometry, then I don't think we will have any impact from the pterygium excision on the refractive outcome. So you can just go ahead and do your IOL power calculation like what you would do routinely for your cataract surgery.
Right, sir. So what is the dosage of 5-fluorouracil that is given, sir?
Well, I haven't used 5-fluorouracil in my cases, but it will be the same as what they use for bleb revision, what the glaucoma surgeons use.
Okay, sir. So one of the viewers wants you to explain a little about the perfect technique.
Again, like I said, perfect technique I mentioned there purely from the point of knowledge, but the perfect technique is an extended removal of the pterygium. That means when we remove the pterygium, we start from the limbus and then we go over the body and we excise at least 6 to 7 millimeters of the conjunctiva that looks abnormal, but we don't remove the normal conjunctiva. Now, in the perfect technique, the excision of the conjunctiva goes all the way close to the caruncle. And the idea is that when you put in your conjunctival autograft, the junction between the autograft and the patient's own conjunctiva is often seen as a ledge, which cosmetically may not look ideal. So Dr. Hurst's technique, because he excises it all the way up to the caruncle, the graft also goes all the way up to there. So you can avoid getting that fold. So cosmetically, it looks very nice. But it's a fairly large surgery which we can avoid by doing a conventional or autograft as well.
Okay, sir. So what if we choose the bare sclera with the amniotic membrane graft instead of conjunctival autograft in cases of recurrent pterygium?
No, even in primary pterygium, when they have compared randomized clinical trials comparing conjunctival autograft versus primary use of amniotic membrane to cover the defect, they have found that the recurrence rates are higher with the amniotic membrane. So for a recurrent pterygium, if you were to use just an amniotic membrane along with mitomycin C, I'm pretty sure that the recurrence rate will still be higher than what you get with the conjunctival autograft. Because we know that in the etiopathogenesis that there is an element of limbal stem cell deficiency as well. So if you don't reconstruct the limbal barrier with the normal limbal stem cell population, the chances of having a recurrence of pterygium is going to be pretty high.
Okay, sir. So there's a question on YouTube regarding can you do rhexis excision of the head?
You can. So unlike removal of the pterygium the body, like to start from the apical cap. So they basically peel off the pterygium right from the apex.
Okay, sir. So do you recommend the use of pre and post operative mitomycin C? Like, do you use or you use it only intraoperatively?
No, I use mitomycin only for recurrent pterygium. But in terms of pre-operative use of mitomycin, if you with a very you can be giving a very source of intralesion. But having compromising from mitomycin over the years, the impact of injection, the impact of use of mitomycin is not immediate. Sometimes there is long-term changes because of the use of mitomycin that are seen over a period of time in terms of scleral thinning. So, unless and until it is absolutely indicated, I would be very cautious regarding the use of mitomycin.
Okay, sir.
But preoperative use of steroids is again quite useful if you have a pterygium that's quite engorged or if it looks very fleshy. Before you do surgery, you can initiate topical steroids for a 3 to 4 weeks and then take the patient up for surgery, chances are your post-operative period will be much more smoother in that scenario.
Okay, sir. And sir, is there any role of radiotherapy in recurrent pterygia?
Maybe like I said, in my clinical experience, I have not. But yes, have a recurrent pterygium, just like the strontium 90 therapy used to be given earlier, there could be a role for radiotherapy as well. But remember that whatever these therapies you use, they always have collateral damage in terms of inducing dry eye, or there can be further limbal stem cell damage when you use radiotherapy.
Okay, sir. And sir, the special demand question, sir, that what is your take on fitness for the consultants, the postgraduates, sir? So your videos.
It's that you can tell somebody and you will start doing it. It's something. Yeah. Am I audible?
Yes, sir. You're audible now, sir. Yes, sir.
In terms of fitness, I think it's always, yeah, fitness is always better to, and then you kind of, you lose that drive to go on with it. But if you're doing it with a group, then you keep joining them for group activities, and then you find that you start getting used to it, and sometimes it's like an addiction, and if you don't do it, you feel left out. So for me, my running and cycling, it's all started with group activities as well. So for running, I'm a part of this group called Hyderabad Runners, and they have a mailing group and a WhatsApp group. So you get motivated by other people who keep posting their activities. Same thing for cycling. We have a group from the bike affair. So every weekend, since people are going in out for cycling rides, so you join them. So it's a question of discipline as well. And a lot of times I plan to go out in the morning, but once I get up, I feel lazy to get up and go, and I feel maybe I can skip. But once you get ready and go out, then you start feeling really well. So I think it's important that at least twice or thrice a week you should have some activity, whether it's playing a sport, cycling, running, swimming, anything that you like. So it doesn't mean that if one person does one particular activity that you have to do exactly the same. You can do whichever activity suits you. It's not necessary that everybody has to run. You can go for a walk. You can do a run walk. So you don't have to become an avid marathon runner just in a few weeks or a few months. But I guess whatever activity you like, develop a habit for it and then sustain it. I think that's something that goes a long way. And if you start magic mantra.
Not audible.
Santosh, any more points you want to add?
No, I am learning from you.
Sir, can I ask one quick question?
No. Please, go ahead.
Sir, do you place BCL in all your cases or only for the cases with large pterygium?
No, I place BCL in all my cases, and it's from the fact that because I place these two sutures at the limbus, and sometimes I do bury them, but if it is not able to, the problem with them is when you try to remove them, the knot can get stuck inside, and removing them becomes a little bit difficult because you yank it out, and the graft, if it is not holding it proper, sometimes the graft edge can also get lifted out when you're trying to remove the suture. And since you plan to remove this suture within a week's time, even if I leave the knot outside, it's easier for me to remove the suture without any difficulty. So to avoid any irritation from the suture, if I put a bandage contact lens, it kind of keeps my patient more comfortable. But on the 5th day, when I see the patient on slit lamp, I do remove the bandage contact lens to just put a stain and make sure that my epithelium has completely healed. So it's good. Pterygium surgery is an art. That's what I would like to tell everyone is that don't take it like a routine surgery. Like I said, that for me, sometimes a pterygium surgery takes much longer than my cataract or any other surgery. But it's something to admire. To a point, surgery, it should look almost like a normal eye. So it takes time, but if you are gentle on the, I think my internet connection keeps getting, yeah. So that's the reason why I like to put a bandage contact lens.
So when you're removing it after 1 week to stain and see the grafts, do you again replace the BCL till you remove the sutures on the day?
If my graft is little, no, like if it is a fibrin glue, if I have done the surgery, then even on the 5th day, those simple sutures, I can remove it by the time my graft has already settled down. Unless I see there is some amount of serous fluid under the graft, which does not occur in every patient, but there can be some cases where you can see the graft ballooning up a little bit. So then you may want to keep a contact lens to try and keep the graft flat. And also, like I mentioned, that I can use a 27 gauge needle to make a few punctures in the graft to try and express that serous fluid so it allows the graft to settle down faster. So that serous fluid is basically an exudation from the blood vessels, and you can see like a clear straw-colored fluid that accumulates under the graft. And also it occurs more common if you leave behind too much of fibrin glue under the graft as well. But if you really express the fibrin glue from under the graft, then your graft will adhere to the episclera much better. You will not, there's not enough space for that fluid to form.
Thank you, sir.
Any more questions, Rolika?
No, sir. Yeah, that's all.
Thank you so much, Rajesh. Thanks for your time and wonderful lecture. I think this is the longest lecture on Pterygium ever.
Thanks for the opportunity. I also enjoyed
Thank you so
doing
much.
this.
Thank you so much.
Thank you.
We'll have you back again. Thank you so much.
Sure. Okay, fine. Bye-bye.